PowerPoint will discuss the common sclerosants that we use in our office, Polydocanol and Sotradecol, how we dilute them, and what the histological results are for the various dilutions. Sotradecol is anionic and polydocanol is non-ionic. Sotradecol has a negative charge and its potency is affected by normal saline. This is related to the critical mycel concentration. The definition of critical mycel concentration is that level above which the addition of additional sclerosant has no effect on the basement membrane. Since 0.9% normal saline has both positive and negative elements, the addition of normal saline will cause binding of the detergent molecule if ionic, such as Sotradecol. Hence, less Sotradecol is available in free solution when dilated with normal saline. Polydocanol is non-ionic and not affected by the type of dilutant. You can use either normal saline or bacteriostatic water. The results are the same. In essence, Sotradecol is more potent when diluted with bacteriostatic water. Bacteriostatic water increases the CMC level of the anionic detergents. Now, this is a representation of a histological specimen. On the left is Sotradecol 0.1% normal saline. You can note that there are no endothelial cells, mild irregularity of the basement membrane. The smooth muscle layer is normal. There is no replacement by fibrin. On the right is Sotradecol 0.1%, 1/2 normal saline. In this slide, you can see there is numerous interluminal debris, as well as thinning of the vessel wall and replacement of the smooth muscle with fibrin. Hence, this is 0.1% half normal saline is much more effective as a sclerosant. In some cases, too effective, and you will have to do a flush of the vessel after sclerotherapy if these debris persist and thrombosis occurs. Sotradecol and polydocanol are detergents. The action of detergents are at the basement membrane of the vessel. Permeability, solubilization occur, as well as the shedding of the endothelial cells. This must occur before the effectiveness of the sclerotherapy can be realized with eventual fibrosis of the vessel. The histological effects of sclerotherapy consist of absence of endothelial cells, interruption of the basement membrane. Now on the histological image, this appears as a ragged appearance of the intima. There can also be replacement of the smooth muscle by collagen in the tunica media, or the smooth muscle wall, the vessel wall. There can also be intraluminal debris, which is not desired. If the concentration is too strong, there can be actual perforation of the vessel wall with the escape of red cells and the results of prolonged staining present. In this image, there is disruption of the vessel wall. Also, there is acute thrombus manifested by the numerous clump of red cells present. For many years, 0.3% Sotradecol was considered the normal concentration for sclerotherapy with Sotradecol. This was published by Treadbar. And however, as you can see from this is much, much too strong a concentration. If you use this concentration, you'll absolutely develop prolonged staining after sclerotherapy. The ideal sclerosant will cause endothelial cell loss and intimal disruption. The smooth vessel wall replacement with collagen is acceptable, and it does signify a more potent sclerosant activity. Vessel wall disruption will cause perivessel inflammation with propensity for staining. This is a diffuse staining that you see after sclerotherapy rather than a linear staining that occurs because of thrombus in the vessel itself. Interluminal debris can cause more intervessel changes, such as acute thrombus formation. So it's desirable after sclerotherapy that you not have interluminal debris. If you do, they must be flushed out. Interluminal debris will cause the vessel to appear dark and acute clotting can occur. Our preferred sclerosant in all patients except those with asthma or inhaler use is 0.075% to 0.1% Sotradecol, diluted with bacteriostatic water. When these dilutions are made, the concentration of 0.1% Sotradecol is half normal saline. The concentration of 0.075% Sotradecol is 0.33% normal saline. This will become evident when we show you how we do our dilutions. First, we're going to make Sotradecol 0.2%. We start with 2 milliliters of Sotradecol 3%. We withdraw 2 milliliters of 0.9% normal saline from a 30 milliliter vial. You add back in 2 milliliters of the 3% to the 28 milliliters of the 0.9% normal saline, and now you have 30 milliliters of Sotradecol 0.2%. Now we mark this as normal saline since this is completely normal saline, and as we add our water, then this decreases the concentration of normal saline as well as Sotradecol. 0.1% Sotradecol is made as follows. Simply add 1.5 milliliters of the stock solution, which is 2.2 Sotradecol, to 1.5 milliliters of bacteriostatic water. Now this will make 3 cc's of 0.1 half normal saline. To make 0.075%, we dilute 0.75 milliliters of the stock solution with 1.5 milliliters of bacteriostatic water. This results in a final concentration of Sotradecol 0.075%, 1/3 normal saline. Now, many times we use this dose in patients that are prone to staining, or that the patients that have staining after previous sclerotherapy with 0.1 will decrease the dose. More about this in the upcoming PowerPoints. Okay, so when Sotradecol is diluted to 0.75%, bacteriostatic water is added to 0.1% Sotradecol, half normal saline. So we add 0.5 milliliters of bacteriostatic to 1.5 milliliters of Sotradecol, 0.1% half normal saline, and now we have 0.075% Sotradecol, 1/3 normal saline. By adding water, the CMC is decreased somewhat, making the sclerosant more active, however, at a lower concentration. Polydocanol, 0.3%. You can see in this slide, there is complete loss of endothelial cells, minor subintimal damage. The vessel wall is intact with no fibrin replacement or no intraluminal debris. Is this the ideal concentration? We think, but however, as you'll see, it's very hard to get an exact concentration that's ideal with Polydocanol, since the range of activity is so small from 0.33 to 0.25, and the resultant changes are marked. To make Polydocanol 0.3%, we add 1% Polydocanol, 0.3 milliliters, to 0.7 milliliters of normal saline. For a 3 cc syringe, or milliliter syringe, you add 0.9 milliliters of Polydocanol 1% with 2.1 milliliters of normal saline. Now, in this slide, you can see this is Polydocanol 0.33%. Every specimen that we looked at with this concentration caused either marked intraluminal debris or acute thrombosis. However, with a percentage of 0.3, did not seem to be so potent, even though it's such a narrow range. However, so it's difficult really to discuss this in a scientific standpoint, since we don't know how the CMC is affected at these low concentrations. But we do know that 0.3% seems to be less potent. To make polydocanol 0.25%, we add 1 milliliter of polydocanol 1% to 3 milliliters of 0.9 normal saline. This concentration is not effective for sclerotherapy in the liquid form. As you can see in this slide, there are still endothelial cells present. The intimal membrane looks intact. So we do not use this for sclerotherapy by itself. However, if you do the foam state of polydocanol 0.25%, you can use this for sclerotherapy of small vessels, but flushing will be required because clotting will occur after foaming the spider complex. Our original concentration that we recommended was for sclerotherapy was Sotradecol 0.15% with normal saline. Now, with the addition of water as a dilutant, this reduces the concentration of Sotradecol that's needed to be an effective sclerosant. So in conclusion, our preference for sclerotherapy is Sotradecol 0.1% half normal or Sotradecol 0.075% 1/3 normal. If you're doing sclerotherapy and clotting occurs, which is manifested by a darkish discoloration of the vessel or that non-refilling quickly, you must flush with bacteriostatic water. We will talk about this in further PowerPoints. Polydocanol 0.3% is our preferred sclerosant concentration when treating these telangiectasia when Sotradecol is contraindicated. Finally, if subdermal tumescent is used as an adjunct to sclerotherapy, the concentration of the sclerosant can be reduced even further. This will be discussed later.